Start. Okay. Right, and we have some. Well, thank you all for being here today. My name is Dr. Karen Viets, and I am filling in for Dr. Jatana Benton-Lee. Dr. Benton-Lee set this all up with Dr. Canty, and we're so thankful for that. At this time, I just wanted to share a couple of preliminaries. There's also opportunity for CEUs, and in the chat, we will be putting a code, and we also have a slide we can show at the end with the code on it, so you can complete the evaluation. And we'll also have a time for questions at the end of Dr. Canty's presentation. And so if you can hold the questions till the seminar is complete, and then you'll have great time to ask. So at this time, I just want to, oh, and I see Dr. O'Connell already put the link in our chat for us for the CEUs. Thank you, Dr. O'Connell. So at this time, I want to share an introduction of Dr. Canty. We're so grateful that you can be with us, and then I'll turn it over to Dr. Canty. So Dr. Lucinda Canty is a certified nurse midwife, author, and associate professor of nursing at the University of Massachusetts Amherst. With more than 31 years of experience providing reproductive health care, Dr. Canty is dedicated to advancing maternal health equity and addressing racial disparities in reproductive health. She is the founder of Lucinda's House, a community-based initiative that promotes equity through community collaboration, education, and support. Her research interests include addressing racial disparities in maternal health outcomes, diversity in nursing, and the history of nursing and midwifery. Dr. Canty draws on her lived experience as a Black woman, along with history, art, poetry, and scholarship, to create innovative approaches to improving maternal health outcomes. She has been recognized as a fellow of the American Academy of Nursing, the American College of Nurse Midwives, and the National Black Nurses Association, where she was honored as a luminary fellow in the Academy of Diversity Leaders in Nursing. Her scholarship and in nursing. Her scholarship and advocacy are also featured in the documentary entitled Everybody's Work: Healing What Harms Us All. We are so grateful for you here, and let's give a warm welcome to Dr. Canty. The time is yours.
Thank you so much, and thank you for having me. So today I'm going to share something that's so important to me in my research, but also the methodology that I use, Van Maten's interpretive phenomenology. And I am going to have time for questions at the end. Some areas I may move through a little more quickly just because I like to be able to have a discussion and really to provide a foundation to why I chose this methodology, but also what I was able to do with the research findings. And so today I'm going to discuss the principles of Van Meter's interpretive phenomenology and just talk about how I used it. And then I would also just like to talk about how it allowed me to use artistic expression. And that was something that was so important to me. And I'll tell you the story behind that as well. And we all know that there's a maternal health crisis in the United States. We know that Black women are disproportionately impacted. No one should be dying during childbirth, but Black women are 2 to 3 to 4 times more likely to die. In some parts of this country is even higher than that, even as far as 9 times more likely to die. And we don't we recognize that you could have all the resources in the world. You could not have any pre-existing medical conditions. You could have private insurance or not have insurance. You could just be financially well off and still die in this country. So for me, I just wanted to understand that. And it's not my experience. And I felt that for me to develop interventions as a nurse midwife, I couldn't do that without understanding what someone's experience was. And so I just want to know, what is the experience? What is it like for someone who almost dies, who comes close to dying during their childbirth or postpartum experience? And again, I want to hear from those that this is their lived experience. And by severe maternal morbidity, I'm talking about life-threatening conditions like postpartum hemorrhage, even antenatal hemorrhage like eruption or previa, pregnancy-induced hypertension, particularly preeclampsia. The women in my study, and I'll talk about these results, but most had preeclampsia. And there was one that had sepsis, but they had conditions where if interventions were done, they may not have survived. So I want to know from those, to see what their experiences were like. And Van Meenen's interpretive phenomenology is more like when you're looking at phenomenology, there's either descriptive, where you're talking about the experience, and then there's an interpretive. And I really appreciated interpretive because I wanted to see how people saw their own experiences. I think it's easy for us in nursing to tell someone what they went through, but I think it's different and I think it's more real when that person tells you in their own words, in their own language, what their experiences was and how they saw things. Because this is really about how you show up in the world and how you're seen and how you lived. And we're going to talk about different aspects of that. But I really wanted something that stayed true to the participants and centered on their voices instead of being on mine. And there's several parts too. There's 6 steps. One is I'm going to go through each one in more detail. Turning to the phenomena of interest is really knowing what you're studying and understanding what you already know, investigating the experience as the person lived it, but it's also about reflection. Not only reflection in the participants, but also in the person who is conducting the research, the researcher. And then it's about writing. And when you're looking at hermeneutic phenomenology, language is so important. And just how are you staying oriented? How are you staying strong and oriented to what is really happening? And that's when we're looking at trustworthiness and things like that to see, are we staying true to what was said in this research? And then the last part is really pulling all these parts together. And I'm going to go through again, sometimes really quickly, but again, I want space for questions. And the first thing is turning to the phenomenon of interest. And for me, it was severe maternal morbidity. And what I still like about interpretive phenomenology, particularly Van Manen, is I don't have to bracket. Because how could I bracket as a Black woman, as a mom, as a midwife? I couldn't like leave those things out and pretend like I didn't know anything. And I really love this methodology because I felt like it made me stronger as a researcher because I was able to look at what I already know. What were my assumptions? What was my understanding? And I have to tell you what I believed was very different than the findings that I found. And I'll give you one example with that. I thought a lot of the experiences would be negative experiences. And what I found is that there was a mix of experiences. So, but at least when you're assessing your pre-understandings, and I had to write this all out, and I have in the references, I have my dissertation, and I really break down things that I had to think about and see where I sit in this and see what I already knew. And it really just helped me to understand when people were telling their stories, I could bring in myself as the midwife. That way I understood the terminology that they used. If there was something that they even needed clarification on what happened to them, I could say, oh, that blood test is this, or this is what that means, just to provide, again, that understanding that they need so that they can be able to tell me their experience. And I feel like that it helped to be a Black woman, to be a mom, to have cared for someone who had severe complications, for the participants, because I was also very open with who I was in this situation. And so I recruited women who had different diagnoses against postpartum hemorrhage, hypertensive disorders, sepsis, any type of bleeding, hemorrhage, whether it was before or after birth, and also anything that related to heart conditions, anything where they felt that, that this was more serious. It wasn't like they just had a bladder infection and they got treated, because that's also considered morbidity. I wanted something to show life-threatening because I want to know what that experience was like. And I did not see a lot of research in the literature that looked at that. Actually, when I look back on trying to learn and understand why women were dying at all during childbirth, there were very limited studies that looked at the lived experience, that did qualitative research. I did several literature reviews, I should say literature searches, and found only like 3 research studies over like 20 years that looked at Black women and their experience. So that's why it was important for me to be able to do a qualitative study and listen again to their stories. I wanted to know who were the people behind the numbers. And I did an initial interview. This was all one-on-one, and this was in person. I interviewed, we had two interviews. One was this initial one, and one was a follow-up to verify the findings and interpret the findings with the participants. And the interviews lasted about 45 minutes to 75 minutes. And all interviews were audio recorded. And I asked about part of their main interpretive phenomenology is asking them if there was something that they had that reminded them or that represented, whether it was art, journal writings, poetry, if there was anything that they had that represented their experience. And the women did not have anything within that category. And I'll talk to you about why that was important to this research. And when you're looking at the reflection, is as you're going through, is how the participant is seeing their experience, but it's also how the researcher is reflecting on what they're hearing. And when you're doing the data analysis, it starts with that first interview. So when you do that first interview, you're looking at it, you're recognizing that there are questions that you should have asked, but that came out through just having a conversation. And then when I did my next interview, I was able to bring that into the next interview. So that was something that was very important. But also, as I was finished the interviews, I had to review the transcripts. And I read these transcripts over and over again. And I remember I read them so much that even in my sleep, I was dreaming about words and things that were said, or I would remember something. And there's several different approaches, looking at the transcript as a whole. And the whole transcript is really your what you're using to pull information from, or that selective piece that you're pulling out things, but based on each interview. And I did that for all. I interviewed 9 women in total, and there was a total, each experience, each pregnancy was considered one experience. So there were 16 experiences throughout all of the women, some of them having one experience and some of them having two experiences because they had one for each pregnancy. And so I was pulling out things based on their own interview, and then I would put things all together. And I'll talk about that when I talk about, as I'm going through the further steps. And the highlighting is really just looking at each line one by one and looking for that meaning. And so I did the selective and highlighting approach. And I'll just show you an example of that. One of my themes was race matters. And from that, I looked at the different participants and pulled out different things that related to that. So anything when race came up, I would pull that out. And also there was a health education that came out. I would pull those out. So these are examples of race matters. And like one participant said, I knew a heart transplant would not have happened for me because I'm a Black woman, and who would give a Black woman a heart? One said, all they do is push nutrition, but they see your skin color, and so they push all these programs that they think that you need because of your race. The other was the person said there is a stigma. There is not a lot of things offered to Black people. They are like they consider us not interested or we don't care. And this participant was saying that she felt that stigma came true. So again, I did this throughout each one, is really just grouping individually and then starting to pull all the statements together. And when you're looking at Van Manen, it's really about how we show up in the world, how we feel we exist. We think about how others look at us, but when we're really looking at Van Manen is how we perceive ourselves in the spaces that we're in. So the lived body, corporality, how is my physical existence? And that's where race came in. The lived human relationality, and that's our relationship with healthcare providers, which was a significant theme that came out of this study. The lived space, and this is really focusing on I'm in the hospital, or I should say what came out of this study is I'm in the hospital, I'm confined to these 4 walls. I don't know whether I'm going to survive or not. And the lived time was really looking at how people reflected back on their experiences. I had someone who was 8 months postpartum, all the way up to someone who was 18 years postpartum. And I'll talk about how that was really related to the results of my findings. And with each theme, and I'll show you, I think in the next slide, how I broke things down. And I'll go a little bit more into my themes. But when you're doing this data analysis, there's a lot of writing involved because again, it starts with that first interview. So you're writing down your thoughts. And I just wanted everyone to know, like I had an audit trail, I had a journal, and I had to reflect again after each interview because they were so deep. And one thing too is like when you don't bracket, sometimes you have to feel. And I really felt these experiences that the women had, especially it being heartbreaking that some of them saying, I didn't know if I was going to survive. And so you're writing down, as I'm writing down their thoughts, I'm also keeping the writings of my journals and other things as well, so that I could remember when I reflect back. Like when I'm interviewing, I want to see like their facial expressions. I want to see when they're becoming emotional. Like the woman who was 18 years, and I still say postpartum. I don't think postpartum ever ends. But I remember like the way that she became very emotional and talking about it. And she said it was like it happened yesterday. And so that was something that was just very important that I had to make sure that I captured what she was saying, but I also thought about what that meant. And so, and language is so important to phenomenology. And again, especially if you want to capture someone's experience, you have to make sure you're taking the language that they're using and you're interpreting in a way that on paper, people can still understand. And this is again how I had to maintain a strong and oriented relation because again, I was able to not bracket. So I had to again keep in mind my own biases. And I have to tell you that I did an assignment during my PhD program and bracketing is really hard. But I remember bracketing and I was like cold. I had to like not have any parts of myself come in. And when I later looked back and was reading and listening to the audio tapes of a assignment that we did, I found myself becoming emotional at that time because I let down my guards and was able to feel. But I have to say that being able to be my true self, I feel like it had helped me to really understand what the participants were telling me and what my role was as the researcher. And throughout this process, I was talking with my research team, my advisors. I made an audit trail. I had field notes that really, I'm telling you, when you're doing your field notes, you got to write down your emotions. You got to write down what you see. Because when you look back at that, it just really brings you to what happened during the interview. So I am a person who, I'm just saying that is so important to have that. And I kept a reflective journal because when someone is telling you their experiences, sometimes it's heavy. But during the time of the interview, you have to continue on. But it's so important to recognize because we have to reflect. So to recognize what were your thoughts and what did you see and what was your understanding. And one thing that was so powerful to me as a researcher was going back to my participants and all of them saying that this is what I said. And what I also did was I added art. So if you could remember, when I said earlier, um, they didn't have anything like a journal or a picture or anything that they saw that represented themselves. And I looked up artwork myself to see, based on their experiences, what am I seeing that represents that? I looked for television shows, movies, art, and there was nothing that really captured that experience of severe maternal morbidity. So I created my own artwork to represent those themes. And that was part of going back to them and showing them what I did and having them say, that looks like me, or that reminds me of my experience, or you capture what I was feeling. And I'm going to show you the artwork very soon. But these are just some examples that came out. So what I did for each interview, you pull out some of those themes and then you look at everyone all together. So I did it individually for the 9 participants. And keep in mind that some of them had 2 experiences of severe maternal morbidity. So I had really things from both. And then I had to pull things out that I saw. And these were things that I saw from one interview, that someone was unaware of their symptoms. They were blindsided by their diagnosis, uncertainty about their future, considering their own mortality. And I just have to say, as a midwife, when I first started practicing, it was really about pain in childbirth. Am I going to survive the pain? And for the first time, the scenarios, the stories started really coming to the surface of worrying about dying during childbirth, even for someone who was healthy or considered healthy before their pregnancy. Someone feeling dismissed, having a positive relationship with their healthcare provider. When I had some participants who had negative relationships as well. learn to be an advocate for themselves. So turning their grief into purpose. Also just the impact that it had on their well-being and them saying Black women are not a priority in our healthcare system. And this is how I grouped up. So I took, again, across all 9 interviews, I pulled out the themes and I categorized them by the lived body, the human relation, the lived space, the lived time. And the lived body is I only know what I know. Race matters, because again, that's the physical part. The human relation was how you cared for me. So either people had positive experiences or they had negative experiences. And I'll talk about that later. But it was the relationship with anyone they came involved with who I consider healthcare professionals. So from the person at the front desk to their provider to their nurse, whoever was involved in their care, that relationship came through in these experiences. The lived space. So being in this space and faced with uncertainty. And again, imagine someone in that hospital room wondering, am I going to survive? And the last is the lived time, and that's still healing. And one of the things that I saw was that regardless of whether it was 8 months or 18 years, most of the participants were still healing from their experiences. And some even would say, I'm in a better space, but I still have not fully recovered. And that was something that was, again, so important to me. And I'll explain to you why. So I know what I know is based on the health information that they knew. Like some women heard about preeclampsia, but they were like, oh, I thought it was just swelling of my ankles. But they didn't even know the severity of it. They didn't know that they could die from it. And they also didn't even know that they were at risk. And there was a participant who was driving around who had a severe headache, but thinking it was because she didn't sleep well. She had some stress in her life. So she related it to that and later actually ended up developing eclampsia because she didn't even know those warning signs until it was a friend that told her, you need to get help. And then her friend, and this is why knowledge is so important, even when her friend said, you need to call the hospital to find, to see someone because this is not normal. And when she called them, and they said, you need to come in. She still didn't see that it was something that was a life-threatening condition. So she asked her friend to drive her, and she developed eclampsia, which is the onset of seizures, on the way to the hospital. This patient and her baby were fine. She delivered at 34 weeks. She actually woke up 3 days later in the ICU. She didn't even know that she gave birth. But one thing that she did tell me is I didn't even know that I had all these signs and symptoms of these warning signs. So knowledge was very, very important. And how you cared for me was either feeling safe and well cared for or feeling like part of someone's routine. And feeling safe and well cared for, those participants said that they felt like they were part of a team with their provider. Their provider respected them, talked to them. One woman said, I felt like my provider went to bat for me. And if it wasn't for him, I wouldn't be here today. So they had very strong relationships that even when, like there was a participant who said that she didn't know she was going to survive. But she said that I realized that my provider did the best that he could for me. And that's why I'm here. Even telling me, and the nurses telling me that any problem is a big problem. But when they were having this positive relationship, they were able to look back on this very scary situation with some positivity. The other side of it was being part of someone's routine and feeling like the person came in the room, they checked them quickly, they did their blood pressure, they did their pain scale, and they left. Like they went through, and it was like it was almost time, one participant said, every 2 hours. Then it became every 4 hours, and then maybe once a shift I saw them. But no one even talked to me about what I went through. And some of the participants felt that they had signs and symptoms, but they weren't heard. Their symptoms were dismissed. And those who had, and or they said that there was no compassion in the care, that they had questions that weren't answered, that some of them said, I'm still searching for knowledge about what happened to me. And those participants felt there was no connection, and they were more likely to complain of racism in their care. And of my participants, 1/3 had negative experiences, 1/3 had positive, and some had a transition. Where there was one woman who they were keeping an eye on her blood pressure. She said that her nurse was trying to force her or pressure her into having a cesarean. But she said her provider was like, we're going to do what we can so you can have a vaginal birth. But then he would leave the room and the nurse would come in and say, You're going to probably end up with a C-section anyways. Just do the C-section. And she said it was a change of shift. And the nurse came in and said, I heard you want to have a vaginal birth. We're going to make that happen. And she ended up having a vaginal birth. So race matters is just showing up in the space. And this picture is entitled Black Woman Pregnant because we're just bringing the race into the pregnancy. And we're not bringing in sometimes diseases or, chronic conditions, obesity. We're not bringing those things in. But once people see our race, it dictates how we're treated within care. One woman told me how she was having chest pains. She was postpartum, about 10 months postpartum, and noticed this chronic fatigue. She said her blood pressure was a little, she was always told her blood pressure was a little high, but never received treatment for that. And then she had a postpartum hemorrhage. And so after her pregnancy, though, she complained of this chronic fatigue. And there was at a point where, and even taking a nap and getting rest, she still felt this tiredness, but thought it was related to breastfeeding. Started having chest pain, went to the ER, and was told, oh, you just have a little angina, just go home and rest. I've never heard of anyone telling someone they had angina and just go home and rest. But that's what she was told. She got dressed. She said another provider came in and said she believes her nurse went and got help. And the provider said, we need to do more tests. And she was in heart failure. Her heart was at a 10% ejection fraction, that if her heart didn't improve in 3 months, she was told she was going to need a heart transplant. And there were two things that she said. One, she was the one that said, who's going to give this Black woman a heart? And the other thing she said was that I believe that I was ignored because I'm Black and no other reason. And she also told me how she was married and they kept coming in saying, someone even said baby daddy, or there was a comment that was made within her care. She's like, no, that's my husband. And so, anyways, she felt that race really had an impact on her experiences. My last two themes um, relate to mental health. One was being again in this space of not knowing if you were going to survive. One of the participants said, I was in the room, they were giving me magnesium, they were giving me potassium, but my blood pressure would not go down. She was like, they were trying all these things, even blood pressure pills, but my blood pressure just wouldn't budge. And she said, I just prayed. I was just praying that we would both be okay. And we were. And this is someone whose blood pressure did not go down until several months after she gave birth. But she talked about that space of feeling like, I'm not going to make it. There was another participant who was a normal pregnancy. She was in labor. Her labor stopped at 6 centimeters. And they came in the room and they said we could deliver the baby now or we could wait another 24 hours. And this was her first pregnancy, 21 years old. So she said you could, she thought the best thing would be to deliver the baby. Had a cesarean, realized that it was taking a long time. She heard her baby crying, and she was like, why is it taking so long? And they were like, don't worry, you're having a little bleeding. We're just trying to stop it. And then she said, minutes later, her nurse said, we're going to have to put you to sleep. You're bleeding. We can't stop the bleeding. And she said how they put the mask on her face to put her to sleep. And all she thought was, in those seconds, if I don't make it, I hope somebody takes care of my baby. And so again, just again, not she actually believed she was not going to wake up, and she did, but she had a hysterectomy as well. And so that brings me to my next theme is still healing. And again, all these participants reflected back. And even I have to also say that they all said that no one assessed their mental health and well-being. Even the young lady I mentioned who had the hysterectomy, she said that I'm in a better place. She's married now. She talks about how sometimes people are like, oh, how come you don't have more kids? You only have the one child. And she realized, she said it opens up wounds that haven't healed. She's like, again, I'm in a better place, but I still feel that there's more information I need. I need to understand why this happened to me. I need to know all these things. And this was 8 years later. And so, but still healing was the theme that I saw for all the women. There was one woman who she ended up having to have emergency cesarean. She had preeclampsia. The baby was at a point that the baby was showing some distress on the monitor, and they rushed her to the OR. She said how they came in the room, they threw scrubs to her husband. Everything happened really quickly. She had an epidural. She said they started cutting and she felt it. And she said, and this is also 8 years out, she said that they just started cutting. She felt it. She said, I feel that. But they kept cutting and they said, we have to get the baby out. She said, this is 8 years later. She was like, I don't even like going to the dentist. The thought of going to see someone and definitely the possibility of having surgery was very traumatizing to me. So I guess she said, I'm still having challenges because I felt that I wasn't heard and I felt like some people caused harm to me and their focus was on the baby and not on me and still has issues in dealing with that and ended up changing her providers after she had her baby. She never went back to them postpartum. And so just putting again all these pieces together is just balancing the research and considering all the parts and components. So knowledge was important, understanding race and racism, the relationship with the healthcare providers. And all of the participants wanted a strong relationship with their healthcare providers. Some received that, some did not. And mental health was also something that came up that I realized that even though someone heals physically, mentally, they may still be going through things from their experience. And what this methodology really showed me, and I'm a true advocate of Van Manen's interpretive phenomenology. So if you're ever doing research and you come out to me, no, that's going to be something I'm going to ask you if you want to do. But this methodology really showed me the power of qualitative research. I feel like I have such rich data. And these findings not only inform, get the words out about what is needed and important in the care that we receive and understanding what someone is going through when they have a complication. It also informed how I educate and I work with my patients. But it also informs my community engagement and even uses for health policy changes. I went to the state capitol to talk about my findings. And there was a legislator that came up to me like 2 years later and said, I didn't really understand the maternal health crisis until you share the stories of those in your research. So again, I'm gonna stop sharing because I do want to take questions and I move quickly because I don't like running out of time and not having time for questions. But just want to share that when you're choosing your methodology, it's important to know and understand, of course, how to implement your research. But it's such a good feeling when you see things all come together. And so, again, this is one of my favorite methodologies. And just want to say one last thing is that I've always loved art, but I've always an undergraduate nursing graduate when I was becoming a midwife. I was not able to use my art. It was like two separate worlds. So this methodology allowed me to show the creativity but also let me tell a story that went beyond words. So I'll stop there and just open it up for questions. And
Thank you
please have some
for
questions for me.
thank you so much for such a phenomenal presentation and valuable information, Dr. Canty. I really appreciate you sharing with us today.
Thank
At
you.
this time, please feel free to ask a question or put it in the chat and I can share it.
And any questions about the methodology or the findings? And I just moved quickly because there's a lot more detail, but I moved a little quickly because again, I want to see what questions you had. Any questions? Oh, oh, I love this question. And thank you for that question, because that was something I did want to touch on. And so the question was about recruitment. And when I was doing this study, I was told that Black women don't like to participate in research. And I was hoping that wasn't true, and it turned out not to be true. And so at the time, I did end up using social media. I used word of mouth. Um, I'm just trying to think. I use word of mouth, the snowball, which was the snowball technique. So if anybody was participating in my study, I asked them if they knew anyone. Um, and I had a flyer. So the picture that you saw, let me see if I can share it, is what I put on the recruitment flyer. So let me share. Sorry, I just wanted to show you if I can get to it. Oh, sorry, there it was. I just passed it. So this picture I actually put on the flyer because I want to catch people's attention and so they could see, maybe they see themselves in this. They could see that it was looking at the experience of Black women. And I actually received quite a few people who, again, a lot of people shared this on social media, like they shared on Facebook. And I also was on, no, I think I was actually only on Facebook at the time, and it was shared like 30 something times. And people reach out because people want to tell their stories. I have to say that. So people even reached out to me and said, I didn't have a severe complication, but I want to tell you what happened to me. And I let them tell me like there was experiences with their care that they wanted me to know about. I've had people who had pregnancy loss and they were like, I know you're not doing this, but if you do a study on this, could you please let me know? Because I want to share what I went through. So, but that was a technique that I used. And I have to say that word of mouth was also powerful, that people who didn't know, who didn't even know me, participated because there was someone who knew me that I either provided care to or they just saw me in a community doing a presentation. So that's how word of mouth also, how people knew about the study as well. But I have to tell you that people do want to participate in the study. And I'll just take two things that also I think helped was having a Facebook profile. That was important because there were people that I met for the interview for the first time, and they were like, "Oh, how is your son doing?" So I'm like, I didn't say I had a son. So I know that they looked up the information on Facebook, because I would share things that, he was going through in school and things like that. So that's how I recruited. Any other questions?
Dr. Canty, there's a couple of very nice comments in the chat. One is from Cami, who said that there's not a question, but wanted you to know that she's new in the women's health space as a nursing director, and these stories are ones that have been similarly shared. It is a crisis, and I'm thankful people are challenging it. And
Yes, yes.
there's also a comment from Nicole. You have truly struck a nerve. These women are very real to me, and I thank you for the work and the art. Continued success to you in every endeavor.
Oh, thank you.
And
Thank you.
there is one more question. Media, is the maternal death rate in Black women mostly related to the lack of adequate care?
Yeah, I would say lack of quality care. So all the women in my study, and again, there were 16 experiences, they all started prenatal care early. Some of the women in my study have from a high school diploma up to doctoral degrees. Attorney, some were in nursing, nurse practitioners, and just different professions. They all had insurance. Most of the participants had private insurance, like 60%, and 40 had state insurance. So I share all that to say that they all started care early. They went to every single appointment. They went to childbirth classes, breastfeeding classes, and still found themselves close to dying during their childbirth. And at the time I was doing this study, Serena Williams, actually, I think I finished my data collection because I was like, how could I add Serena Williams into my dissertation? Because at that time, this is a woman who had everything, even was a picture of health, and almost died because she wasn't heard. So I would say you could still say adequate care, but it's not on the part of the woman. And that was the part that I really want to stress is that these other participants were in the system getting care. And there were still times they weren't heard. Some of them having symptoms. The woman having chest pain being told to go home and rest. I never heard like angina is serious. I never heard of anyone saying a little angina. So there's definitely something within our healthcare that we have to look at and think about. So, and this is still, we're still evaluating this. I can share that I recently did a study on transportation. And when you first hear transportation, you think just only about access of care, for care or to care. But what I found is that transportation is really a stress for those who even have cars or transportation, who have means, that there's still so much involved. And so that's why I loved, being able to hear their experiences because I was able to really show how those factors that show up in their care, that could either be supportive or that could be that create a crisis or be a source of trauma. So that was something that was important. Yeah, thank you. Thank you for that question.
Any other questions or comments for Dr. Canty?
Well, I would like to share something while you're getting some questions. A couple things I went through quickly, and one is that I love qualitative research. I appreciate quantitative research, but when I first started looking into this, everything was epidemiological studies. Everything identified the issue. Like there were studies that said, that Black women were more disproportionately impacted, but there was nothing to say why. And so for me, it was important to be able to go behind the scenes and find out the stories. But I find myself now in this stage in my career is really looking at mixed methods. So, because there was a time I wasn't feeling quantitative research, I'm just going to be honest, because I saw so many numbers. So I feel like the mixed methodology will really help even tell a better story, a stronger story.
Thank you, Dr. Canty. We have one more fantastic comment from Bridget, which says, "This is amazing research. Thank you for sharing it. So important. I love the art. You just answered my question about how the art impacted the willingness of the participants to share. I'm interested in how we can use art in nursing, even at the bedside." And adds, "I'm not artistic, but as an educator, I see the value." I echo that. I'm also not artistic, but I appreciate the value.
Yes.
So
Well, I
thank
want to
you.
say, I do want to say that there's an artist in everyone. There's an art. And I'll tell you two experiences that I've had, and how I use art. So again, I always had art as separate than my nursing, than my midwifery. And as an educator, I always kept them separate until I did my actual art in my research. And so my students had a paper. Was working with seniors. They were in community health. They're ready after spring break. I feel like you lose them. I feel like they have spring break fever. So nobody wants to write a paper at the end of the semester. So I changed it into an art project. And everyone's face, they lost their color. They were like, "What?" And students were like, I'm not an artist." But I told them, you know, they could use any medium of art that they wanted, from drawings to photography. Some students end up using dance, poetry, and they were able to. Well, I should tell you what a student told me. They said this was the first assignment where I was able to say who I am and what's important to me. I had them use art to represent their philosophy of nursing in an area of nursing that they're interested in, whether it's right after they graduate or in the future. And the students really just opened up. And so that's how I use it in my education. I use photos a lot as well. Like especially online, I'm like, what are three photos that represent who you are? So I integrate art in that way. And I had a shift from using art, and I still use art to represent my themes. But last year, I met with a group of we actually met over the beginning of the year, creating and developing our own art. We would get together and talk about our own experiences, and it was an art program, a maternal health art program, to give us spaces to tell our own stories and to create something from that. And then we shared our art at three art shows in a community. We went to like the local community library and displayed our artwork. And these were all women who were, well, there were one that was pregnant and ended up delivering her baby during, and everyone else was like new moms or different stages of being in motherhood. And we all created our own art. And I didn't go in as a researcher, I went in as a participant as well. And my son is 16. But this project helped me to even just reflect on my own experiences during the pregnancy and think about things I didn't think about. But the women, there were some that said, like you both said, I'm not an artist. They were like, I'm going to do stick figures. And by the end, when we created our artwork, everyone had beautiful pieces. No, not one stick figure. And we even did our own self-portrait. So and I said, this is how you show up and how you believe you see yourself. And we had such a good time in doing that. And so sorry, let me stop sharing. Sorry. And so anyways, that's how you can use art. So it doesn't have to be, it could be for your art to represent your work, but I think that sometimes when you have, like there's someone I'm working with now, and has to be on bed rest. So I talked to her about journaling and doing different things. And that was, it was just amazing. And it also helps people to reflect again on their experiences. Okay, I think I saw a question, but it went really quick.
Yeah, it just popped up. Thank you for that response as well, Dr. Canty. The question is, was it difficult getting IRB approval?
No, no. The IRB approval, even though where I was at University of Connecticut, they have a very, it does take a little time. The only thing that came back to me to revise was they wanted more clarity on how was going to store and protect the data. So at that time, this was 2019. At that time, I think security now and having shared drives is a little bit easier and more protective. We had having a password protected device. So they just want to see how I was going to keep everything safe. And like my transcripts, I printed up because I was writing on those. So they just want to make sure that was safe. But as far as the artistic piece, the information, and I know, for example, like whenever you're doing any kind of research, you want to make sure that people are safe. That's really the primary reason for the IRB. And I had, dealing with something so sensitive, I want to make sure that if emotions did come up, that I would have the right support for them. So I made sure I had a list of resources where people could go for care, for, mental health support, and even from my own background was able to offer support if needed. So I think that helped my IRB application go through faster.
Thank you. We have another great comment from Kelsey. One question and some comments is, did any of your participants discuss the role of racial concordance and feeling like they would have had better experiences if they had providers of color or specifically Black providers? And then Kelsey also adds, thank you for your advocacy for Black mothers like myself. You are a true nurse, CNM healer.
Oh, thank you. Thank you so much. And that did come up during the interviews. Just seeing someone who looked like them, they felt safe. They felt like someone understood the culture. They felt that there was a little more TLC in the care. And that's, what the participants said. I did also see that there was positive relationships with providers who did not look like them as well. So there were people who were so like there was a woman who had the cesarean that she felt the pain when she went back for her second pregnancy and had to have a repeat cesarean, which she was terrified of. She talked about how the anesthesiologist came in and said, "What happened to you should not have happened, and I'm going to make sure that doesn't happen." And that was not someone who was of the same race. But participants did say feeling discomfort when they went into a space, like going into the OR and not seeing anyone who looked like you, going into the ER and having, telling your symptoms and feeling like the provider who was caring for you was almost mocking you. There was an experience where a woman came in who was leaking fluid, but she was told it was normal discharge and was leaking that for a few weeks and went back because it was getting heavier. And then even that person popped in and was like, that's, oh, you're here for the same thing. And it turned out it was her fluid. And so, but she felt that because of race, that person again ignored their symptoms and made her feel like she was exaggerating. So we do know race does play a role. And there is a comfort when there is a provider that looks like you caring for you.
Thank you, Dr. Canty. Any, I think that was the last question in our chat as of this time. Anything else before we end for the day?
So just don't be afraid of qualitative research. There was a couple quantitative people that pulled me in and I pulled them into qualitative. And what I found is, and I just even talked with a student who said, everything I'm learning focuses on quantitative, it focuses on surveys and really things that you don't have to personally interact with someone. But now she received a grant that she's working on a project where she has a quantitative component, but she can also do interviews. And she was very nervous about doing that. And I just created a environment of support that we did the focus groups together, and she was amazing. But again, if you're not exposed to that, it seems very scary. And sometimes it is easier to just give out a survey. Even I think about, that there was I saw the link to the evaluation, and it's easier to just give the evaluation and read it later than to ask all of you right now, tell me how I did, because I would be very nervous. So it is scary. But I just want people not to be afraid of it and to give it an opportunity. But also, I know in some spaces, people value quantitative findings more, but just to say that qualitative results are so rich as well and can really impact the way that you provide care, the way that you look at things yourself, even as the provider. So I just want to open up to people who are thinking about it to realize how valuable that it can be.
Thank you. And I totally agree with you. And I love that collaborative spirit that we help each other out. For
Yes.
those of us who might want quantitative or qualitative, but coming together and working together. So that's awesome.
Yes.
All right. Well, one last ask for any questions or comments. Well, I want to thank you, Dr. Canty, once again for this
Thank
fabulous
you.
presentation. And I also want to thank all our participants who gave of their time and their wonderful thoughts. Thank you very much. And I hope everyone has a lovely day. And if you want some CEUs, there was a link put in a couple times, and please take time to fill that out and use your CEUs. Thank you again, Dr. Canty, and
Thank
everyone else.
thank you
All
for
right.
having me, and thank you all
You're
for coming.
welcome. You're welcome. A lot of thank yous and accolades to you in the chats there.
Oh, thanks, everyone.
Yes, thank you. Bye bye for now.
Okay, bye everyone. Take care.